Well, Ben, today we talked about hip pain. I talked a lot about how really Sherlock Holmes inspired me in medicine to really consider every option for a patient, every diagnosis, not just looking at, oh, they come in with hip pain, it's definitely the hip, right? As you approach physical therapy and when you're dealing with patients that come in, it's hard because I think you guys are put in a position where you almost aren't allowed to be as much Sherlock Holmesy, meaning that you're given a diagnosis and you're almost often given a treatment recommendation from the surgeon. How do you take that that initial order from the surgeon or the physician and then still be able to apply kind of some Sherlock Holmes and diagnosing what's going on? Is because, as you know, we're not perfect. We may miss a couple things that's going on as well with the patient. How do you approach it with patients when they come in?
Great question. I think the biggest thing is who's it coming from. I mean, if we have someone that we know and trust their assessment, we'll still piggyback that and do our own assessment. But someone that's we trust, we'll lean into that a little bit more. Most of our referrals come from those who are not going to do a thorough evaluation as you would, or maybe other orthopedic surgeons. So we still have to dig in and find out for ourselves. Most of the treatment of physical therapy focuses on their limitations, and so we're looking at how are they walking, how are they moving, and regardless of diagnosis, there's still some limitations that we'll still have to look at. So they may come in with a very narrow diagnosis, but we still have to look broadly and see how they're functioning and really tailor our treatment based upon that.
Have there been any examples that you can come up with, and I'm putting you on the spot, of any patients that you maybe applied the Sherlock Holmes principles a little bit more and figured out something that you didn't expect, or maybe that the patients didn't realize was going on?
Honestly, I think most patients we see come in and either they have a perception that it's my back or it's my hip, or they come from a diagnosis. And I think most we have to apply that. We have to dig into it. And it really is the part of therapy that I love is watching how they move, lining up things, looking at all the data sets, and from there deciding upon the best treatment option. And it truly is like discovering something that they don't see or maybe hasn't been seen, and it's happened multiple times. And so
one of the reasons why I picked the hip in discussing this is because I think there is a lot of overlap with the hip versus back, and even one of the therapists had mentioned after the rounds discussion that, hey, maybe consider, post-hysterectomy patients can have some referred pain in that area as well. And it's a very good point. I didn't touch upon that, obviously. But as you address patients with hip and back pain, because often they're together, what unique treatments how do you approach that differently when you're dealing with back and hip patients when they both have the same diagnosis?
So they're coming in with both diagnoses. I think we look at where it is impacting their life. Is it really they can't sit for very long? Is it really because how they load their spine, something is happening? I think that we look at what is impacting them the most. And we kind of start from there and work our way down. And if you come into a therapist and you have multiple problems, if a therapist takes it on and they try and do everything at once, you're going to lose. And so I think identifying the biggest pain factor, the biggest limiting factor, and start there and work our way down. And that's probably been the most important thing. And you really have to educate and talk with a patient, make them a partner in that, and say, hey, we're going to focus on this. We know that we have this, but we're going to focus on this and kind of see how far we can take this, knowing that we do have this to work on.
Yeah, I love that, because I think a lot of times we as clinicians neglect to realize that our greatest asset is our patients. I think Shauna Edwards talked about that during the summit meeting in September, where the patients really are our best helper. And I think if we can educate them, like you had just mentioned, about what is going on, and the fact that if they have both back and hip pain, how to turn their ideas on to say, hey, when you recognize this pain, this is what's going on with your back, maybe consider this, or with your hip, address this. I think the more we educate them, number one, the better they're going to be able to do on their own, because as you know, therapists can only do so much per day, per visit. It's what the patient does at home. And same thing as a surgeon, I can only get so much information. Frequently the patient comes in and says, well, it's not hurting today, just like the car that's not making the sound as they go to the mechanic. But as we educate them, okay, well, look for this, and maybe have a pain diary and do those things to kind of help with that investigation, those more data points like Sherlock Holmes talks about. I think patient education, getting them involved, I think is key with it. When you're doing that with therapy, how do you send patients home to do their home exercise program, and what kind of education do you give them as far as gleaning more information about what they're dealing with and how to help you more as they come back and see you? How do you educate them to be prepared to be a better helper?
Oh, that's great. I love to have them part of the process. I love opening it up and saying, okay, this is why I'm thinking this, and this is what I'm looking at. You get them involved, and they really appreciate it. They'll come back with much better data. Yeah, I see what you're saying here. I tried this, and it really irritated it, and that kind of lines up, and you really kind of bring them into the process, and you get a lot of good data from that. So
yeah, and again, I think patients are I think they're getting more educated. They're understanding more. This is not just a patriarchal treatment system where we're just, hey, this is what's going on, this is what we want you to do. I think it's nice to see when patients do come and they're educated and they're involved and they're wanting to do more. It definitely helps the process.
Yeah, I think early on coming out of school, you have all this knowledge and you're so ready to, no, that's not it, that's this. And as you gain experience, you see, no, let's appreciate where they're at, where they're seeing things. Let's work with them where they're at. Let's kind of bring in what we have and kind of see where we can come together.
Well, and that's why I love what we do as a group with rounds and with our summit meetings, is not just involving patients, but each other. I mean, I've learned so much from the therapists and the chiropractors about, hey, when I'm considering this approach, consider this as well. It's something I wouldn't have learned in, specifically in orthopedic medicine. Bringing chiropractic into it and bringing therapy and OT and all that stuff, really helps as we get everyone together.
Yeah, I love. It's great to be a part of a group of individuals that all want to help the patient, and I sincerely believe that we all have that desire and we all have perspectives we're coming from. And same thing. I really appreciate seeing how. Okay, I can appreciate where they're coming from on that. I see where they're approaching it this way, and it's really rounded out my practice too. So
yeah.